All right, this is chapter 12 from the 11th edition of the textbook of radiographic positioning and related. This begins on page 458 of your textbook. So this picture starts off figure 12.1. This is just kind of showing you the relationship of where and the gallbladder are. You can see they've got the right hemidiaphragm outlined here and then the left hemidiaphragm here. So the liver makes up the majority of the right upper quadrant, as you can see right here. And if the patient still has a gallbladder, it will be nestled up underneath the actual liver. The liver is the largest solid organ in the body. It weighs approximately 3 to 4 pounds, and it makes up 1/36 of the patient's body weight. You can see by this relationship, when we do air fluid levels in the abdomen, we talk about the fact that we look for free air between the liver and the right hemidiaphragm. That is the area that we would be looking, if that was the case, to see if there was any free air in the peritoneal cavity. Figures 12.2 and 12.4 are represented here. This is 12.2, this is 12.4, and this is showing the 4 lobes of the liver. So the liver has 2 lobes that you see from the front, which are the right and the left, and the falciform ligament is what separates the right lobe of the liver from the left lobe. If you were to look at the backside or the inferior view of the liver, you would also see the other 2 lobes, which are the quadrate lobe and the caudate lobe. And then you can see the gallbladder from the back here, right next to the quadrate lobe. And then you can see that the caudate lobe literally lies along the inferior vena cava. So these 2 pictures are also on page 458. The root of the bile. So bile is one of the main functions of the liver. The liver performs actually more than 100 different functions, but the one most common to us in radiology would be the production of bile. Typically, the liver produces about 1 quart of bile per day, but that is completely dependent on the patient's diet, because bile actually functions to break down or emulsify fats. So if a patient has a high fatty diet, then they might produce more bile than 1 quart a day. Bile aids in the digestion of the fat by breaking down the fat globules, and it also helps with the absorption of fat following its being digested. Bile also contains cholesterol, and that is one reason when people have hyperlipidemia or high cholesterol. Sometimes when they state that it's not diet related, but it's hereditary, that's why, because the liver, the bile that is made by the liver contains cholesterol. So sometimes it's just a matter of genetics that would cause that hyperlipidemia, not necessarily a patient's diet. This picture right here is referenced in figure 12.5 on page 459, and this shows once bile is made in the liver, it literally comes out of the liver through the left and right hepatic ducts, which are right here, and then it comes down the common hepatic duct. If it were to be used right away, it would come down the common bile duct. It could potentially join the pancreatic duct, and all of the bile and the pancreatic enzymes would dump into the descending duodenum. If the bile was not needed right then it would be made in the liver, come down the left and right hepatic duct into the common hepatic duct, and then it could pass through the cystic duct and be stored in the gallbladder for later use. We will look at this a little bit later on, but these older terms like pancreatic duct is the duct of Wirsung, and there's a few others that we will look at, because a lot of times on the registry they like to use these older terms in parentheses versus the more common modern terms that you see there. This right here having the pancreatic duct and the common bile duct form one passageway into the duodenum is significant as well. This happens in about 60% of the population, that they form one passageway. And in 40% of the population, the common bile duct would be one entrance into the duodenum, and the pancreatic duct would be a separate entrance. This is figure 12.6 on 459, and notice the gallbladder has a distinctive pear shape to it. So you've got the fundus of the gallbladder on the bottom here, opposite of like the stomach where it's at the top. Then we have the body. The neck is kind of where it narrows down and comes together. And then you have the cystic duct, which is what takes the bile into or out of the gallbladder. So it definitely has a pear shape to it. The functions of the gallbladder, there's three primary functions of the gallbladder. It basically stores bile, it concentrates the bile, and it's designed to contract when it gets stimulated. So if bile is not needed immediately, once it's produced, it gets stored for future use in the gallbladder. So it's kind of like a storage holding unit. The bile then gets concentrated within this gallbladder as a result of hydrolysis, where it removes water, and then at times when too much water gets absorbed and the cholesterol gets too concentrated, that is when choleliths or gallstones can be formed in that gallbladder. When a patient eats, the gallbladder typically will contract when fatty foods or fatty acids enter the duodenum. It stimulates the duodenal mucosa to secrete the hormone cholecystokinin, CCK. When there are increased levels of the cholecystokinin in the blood, the gallbladder will contract, and the terminal opening of the common bile duct right here, that will actually open and allow the bile to dump into this descending duodenum. So we're going to look, again, it'll bring up the same picture, but notice on 459, this is referencing figure 12.5, but they reference that the common bile duct and the pancreatic duct, like I said, in 60% of the population, they join to form one passageway into the duodenum. The reason that's significant is because if a patient were to get a stone in here, not only would it back up the common bile duct, but it would also back up the pancreatic duct. That could lead to pancreatitis, it can lead to hepatitis, and it could lead to cholecystitis. So this one passageway happens in about 60% of the population. The other 40%, the common bile duct makes one passageway, the pancreatic duct makes a second separate passageway. As far as the relationship of the gallbladder to the ductwork, typically the gallbladder sits more anterior in the body, and the common hepatic and common bile ducts sit more posterior. That was important with imaging because when we image the gallbladder, we tend to place the patient prone or PA so that the gallbladder was closer to the IR. If you were trying to look at the ductwork, then the patient would be supine or AP. This is not in your book, but this is an old image film of a gallbladder study where the patient would ingest oral cholecystopakes. They would take in the cholecystopake and it would cause this concentration of the contrast media in the gallbladder. You can see down here is the fundus, the body, the neck of the gallbladder, and then you have this cystic duct. So we would take one picture of the patient like this, and then the patient was given a contrast media called fatty meal that would cause that gallbladder to contract, and you could actually watch under fluoro as the gallbladder contracted and the barium was expelled out of the gallbladder into the descending duodenum. This is a sonogram which has significantly replaced imaging for the gallbladder. There's a few reasons why that is the case. There's four main reasons. Sonography does not use ionizing radiation, which is better for the patient, lower patient dose. Sonography can detect much smaller calculi or stones than radiographic imaging can. There's no contrast media used in that exam, and there's less patient prep for the exam. Typically, patients having an ultrasound would just need to be NPO, or nothing by mouth, for at least 8 hours prior to the exam, and then they could have the sonogram, which would show smaller stones without using radiation. No contrast media is required and less patient prep, so all around better for the patient. This next slide is the one that I was talking about, why this is important, and this is referenced in figure 12.7 on 459. So some of the older terms that are important to know would be the duct of Wirsung is the pancreatic duct, the ampulla of Vater is the hepatopancreatic ampulla, and the sphincter of Oddi is the hepatopancreatic sphincter. So this is referencing 60% of the population where these join and form one passageway into the descending duodenum. What they're trying to reference is that in other types of patients, what can happen is you would have this common bile duct would come down as one passageway, and then the pancreatic duct would enter as a separate passageway, so that you had pancreatic enzymes coming in here and then bile coming in here. That would be ideal, but in this case what they're showing us is that the bulk of the population tends to have where they join together, which if there was stone formation or the stone lodge could be detrimental for the patient. So these terms in parentheses, they do like to use on the registry, so just be mindful of that. And I would study both terms on here, the current terminology and then the older terminology. Typically this Wirsung, Vater, Oddi, those are the doctors that first identified or visualized those areas. That's why they're typically named with people's names, versus like hepatopancreatic implies the liver and the pancreas. So the sphincter that allows the bile from the liver and the enzymes from the pancreas to pass through. This is what relaxes when CCK is present in the bloodstream. Two other exams that we have to look at in order to call our gallbladder lecture complete would be an endoscopic retrograde cholangiographic pancreatography. That's a mouthful. This is on page 733 of your textbook. So we usually refer to this as an ERCP, mainly because that title is ridiculously long, but that title, what it stands for, an endoscopic, means that they place a scope within the patient or inside the patient, and what they do is they inject contrast media through the scope, retrograde or backwards, through the common bile duct and the pancreatic duct, and they look for stones or strictures or anything that could be causing an issue. So on page 733, you can see a picture in figure 19.19 of the endoscope going in the patient's mouth, down their esophagus, through the stomach, into the duodenum. That would follow the normal flow. Then when it gets there, they take that scope and they actually put it up into the common bile duct and or the pancreatic duct, and they're looking for any stones or strictures, which that's a narrowing of the passageway. That's what they're looking for, trying to figure out what might be going on with the patient. And then usually they can place the scope in the common bile duct or the main pancreatic duct under fluoro, and they're actually able to see. Sometimes they can go in if the stones are small enough, and they can actually grab them with like gator forceps through the scope, and they can actually kind of crush the stone. Sometimes I've seen that done before, where they crush the stone and then all the bile and the pancreatic enzymes that have been backed up in there, and it almost looks like infection because it's cloudy and it just kind of starts pouring out. It's super interesting, but kind of disgusting at the same time. So this is one exam that we used to be heavily involved in. Now these tend to take place in the GI labs because the GI docs tend to have their own imaging centers and their own surgery centers. So you may or may not see one of these out on clinicals. If there is one coming in, I would highly recommend you go watch it because they are extremely interesting to see done. Last, we have what's called a post-operative cholangiogram. So post-operative means after surgery. So on page 732, you can see that this is called a post-operative cholangiogram or a T-tube cholangiogram. So typically, once the patient has had surgery, the surgeon could be concerned about any residual stones left in the biliary ducts that were not noticed during surgery. So if that's the case, they can place what's called a T-tube catheter into the common bile duct during the cholecystectomy. So when they're taking the gallbladder out, they can put this flexible T-tube catheter into the common bile duct. And what happens is, I'll try and show you with a drawing here. Okay, so this right here, this part is outside the body. And this T-tube is literally placed like that. That's why they call it a T-tube. It literally looks like a T. So this part comes outside the body. And after surgery, the patient would come down and the radiologist would inject contrast media into the patient through this T-tube and basically watch under fluoro while it flushes any residual stones out. So when they push contrast in this particular patient, you can see right here, this is the right hepatic duct, this is the left hepatic duct. So contrast flows freely back into the liver, and you can see when it flows this way, it's flowing into the common bile duct, and then eventually it is dumping into the descending duodenum. So if there was any stones left in there, that contrast, pushing it like that, would ideally cause it to dislodge, and it would end up in the duodenum, which would not be a bad thing because it means the patient would simply pass that through their fecal material and they wouldn't even know it. But if the surgeon's concerned about that, they can put this catheter in at the end of surgery and send them to radiology to have that done. And then when we're done, so it comes to us clamped. The radiologist would unclamp it, push the contrast through and take some images. And then once everything is satisfactory, that there's flow in both directions and we've got spillage into the duodenum, typically they would just pull that T-tube catheter out and they would put little steri-strips over the surgical site because this T-tube catheter, you can see it's very small, so it doesn't take a lot, nor does it leave a huge hole in the patient. It tends to heal and close rather quickly. So a postoperative, or what's called a T-tube cholangiogram, is on page 732. So make sure you listen to this, write down any questions you might have, and then when we meet again in class, hopefully I can answer them and we can have further discussion. All right, thank you so much. Have a great day.